Good morning. Happy December 16th, halfway through December, almost Christmas. Today we're going to be doing our monthly webinar, and it's going to be on joint health, which I know everybody's interested in. I'm being an orthopedic. Hopefully I'll be able to tell you just a little bit about the science of joints and why they're so cool and how they work and why yours might be achy, creaky, or stiff and what you could do about it. And then just so you know, I've written a book to help you guys all treat yourselves non-surgically, hopefully. And then if you have to have surgery to have better outcomes, and the book is on pre-order. This has been like a 2-year project. What's that? Yeah, we're going to show you at the end, but I'm very, very excited. It's been accepted for publication and it's going to be published, I believe, in the spring. And my publishers, Ben Bella, are doing some final work on it, but we're super pumped about it because it's basically going to be a guide for different tips and tricks of what you can do for yourself. And you can refer back to it, and it just helps you understand that there is more to getting better than just surgery and injections. At least that's my hope for you. But today we're going to talk about joint health. We're going to dive into it. And there's going to be a couple little technical parts, but not that many. So just stick with me. Wow. Okay. Next slide, please, producer. Okay, enough about me. I'm Dr. Meredith Warner of Warner Orthopedics and Wellness, which is my private practice in Baton Rouge, but I'm also the founder of Well Theory and also the Healing Soul, which is really what started me on my path of empowering you to take better care of yourself. The Healing Soul is a flip-flop I designed to treat foot pain so people could self-treat over and over again in an affordable way without having to waste time and effort going to a doctor's office to get potentially damaging things like injections and surgery. All right, this is my clinic. All right, I'm being distracted right now, sorry. All right, this is my clinic in Baton Rouge, and just so you know, I really think about everything health and wellness. And just even my clinic, we have aromatherapy, we have a lot of natural light, we've got big, wide open spaces with colors that impart warmth and health. So there's just so many different things you can do to improve your overall wellness and just make yourself feel better on a daily basis that don't involve heavy pharmaceuticals, if you know what I mean. Okay, next. All right, again, joint health. So this is really for you to have just a bit better understanding of your joints, okay? So we're gonna go over some concepts. We're gonna talk about how the joints maintain themselves, potential treatments, and really what's more important to you than treatments per se is preventing problems. So there's different types of joints. There's a structural classification and then there's a functional classification, meaning you could have a structure like, oh, that is a square, or you can have function. Oh, that square is supposed to go into a hole that's shaped like a square. That is what it does. So some of us classify them with structure, some with function. I'm going to go through really more of a structural classification for you, talking about mostly synovial joints, because those are mostly the ones that people think about when they think about achy, creaky joints. And then, like, how do they work and what do they do for you? And then we're going to get into the basic science and then different things you can do to make them better. All right, so what is a joint? It is an articulation, meaning two parts moving against each other. So, for instance, your finger joint, there's a phalange bone, another phalange bone, and there's a joint between. So the joint allows a smooth, friction-free movement of a particular bone so that we can exist in space and do things. Um, so the joint form dictates function. And you'll see this a lot in the human body and in nature. Form follows function, okay? So how something is shaped and its material properties often dictate what that thing does. So for instance, think of a wheel. It's round, right? And it has a smooth surface. So generally, that is going to dictate that it rolls, right? You're not going to bounce a wheel as much as you're going to roll it, as opposed to like a basketball, which is a spherical air-filled structure with rubber. And so its form dictates that it bounces and you can throw it around. So those are some simple examples. We're going to talk about the shoulder, the hip, the knee, the ankle. These are ball and socket and hinge joints. And then we'll talk about the synovial lining and synovial fluid, which is what kind of surrounds joints and keeps all of the joint materials, I guess, inside of the joint so they don't spill out into the surrounding muscle and tendons and ligaments. We'll talk about cartilage, which is, of course, one of the most important structures inside of a joint, the underlying bone and how important that is, and then the different support structures, which are all really just connective tissue. So, orthopedics is really the management of connective tissues, if you think about it deeply, in addition to the musculoskeletal system, which is comprised mostly of connective tissues. But then we also have dynamic support to the joints, which involves a significant amount of neural feedback. So your brain needs to understand where you are in space, proprioception, and it needs to have a sense of gravity and a sense of balance and a sense of reactivity to certain movements. So a lot of what your joints do, they're doing without you having any idea that it's happening because they're all reflexive pathways that have developed between the brain and the joint to maintain your ability to stand, walk, get up from a chair, things like that. And that involves neural feedback and muscle and the muscular attachments to the tendons, which are then attached to the bones next to the joints. All right. So joint is much more than just cartilage, okay? Cartilage is merely the low friction surface that coats the ends of a bone. Joint involves the synovial fluid, the synovial lining, multiple connective tissue cells, many immune cells, and then there's hyaluronic acid, and the synovial fluid acts like a shock absorber. It increases viscosity of the liquid inside of the joint. It allows for some dispersion of nutrition. If anybody out there has ever had a Synvisc injection or rooster comb or HA injections, this would be if you went to the doctor's office and they did a series of 3 injections in your knee, typically, because that's the only place this has been FDA approved by the, I'm sorry, FDA approved. It hasn't been approved for any other joint, although they're all really the same when it comes to synovial joints. Um, those injections are mimicking or meant to put a component of the synovial fluid back into the synovial fluid. So the hyaluronic acid allows better viscosity or thickness of the liquid and better lubrication of the joint surfaces. So lubrication is needed for the joints to have a low friction um, paradigm to allow better movement. Think of a ball bearing. Without oil in your engine, with a ball bearing, everything would lock up, cold weld, and there would be no movement. You have to have some kind of lubrication, and these HA injections help with that. This slide shows you a normal joint with those structures we just discussed, and then one with rheumatoid arthritis. Rheumatoid arthritis is, of course, an autoimmune disease where you self-attack, and in particular, synovial cells and synovial lining get beat up by tumor necrosis factor alpha and other highly inflammatory proteins involved in the immune system. And so all of the normal relationships between the fluid, the cartilage, the synovial lining, the synovial cells, the subchondral bone, et cetera, are disrupted just because of inflammation from your immune system. So those are some basics about some of the superstructure and the hyaluronic acid. Now let's talk about some form and some function. So there's gonna be different types of joints. So pivot joints. A pivot joint, like the atlas and axis of your spine and the upper cervical, allow your head to pivot. In the radius, the reason you can do this is because the radius, which is the bone on the thumb side of your forearm, has a pivot joint with the humerus, okay? And it allows the radius pivots around the ulna, which is a hinge joint. And so that's why your elbow is able to do this and this, but you're not able to do what a shoulder can do with your elbow, correct? So that is a pivot joint. I've lost my producer. I'm trying to think if there's any more examples in the body I can share with you. I don't think there are that off the top of my head right now. Then there's a hinge joint. We just talked about one in the elbow, but the elbow has 2 types of joints. It has a hinge at the ulna and humerus, pivot with the radius and the humerus. The knee you can think of as a hinge joint because you're really just mostly doing this. There's a little bit of play and a little bit of side to side and some rotation in the knee, but mostly its job is to impart forward force and let your quads work to get you up and down off of things, okay? And then there's fingers, toes, elbows. We talked about the elbows. We briefly talked about fingers and toes. These are all hinge joints, and they allow the transmission of force from the tendon muscle unit. So you can have very, very strong hinge joints because the force is all in one vector of, I guess, one line of force. So it's not dissipated into rotation and side to side. and then the ball and socket joint. So if you were just made of hinge joints, you would be like a robot, really. Like there's not a lot of movement. Well, now robots are probably much more advanced than that, right? Ball and socket is what lets us exist in space, in a 3D space, and do things. So the reason you can reach all around is because you have a ball and socket joint in your shoulder, and you also have one in your hip. The reason you're most of us, the reason the shoulder has far more range of motion than the hip is the socket itself. So in the hip, the socket is very big and almost spherical, and it's very conforming to the shape of the femoral head and neck. Okay, and so your hip can really only kind of exist within the range of motion allowed by that socket. The shoulder is a much more shallow socket, and it allows a lot greater range of motion and sliding. So the shoulder is a little bit different type of a ball and socket joint, but that's why we have such incredible ability with our shoulders to do things. And then you have sliding joints. So your wrist is a sliding joint. There's different little bones in the midfoot that are sliding joints. And these really just have a plane of motion. They don't really do much else. Okay. And they're obviously going to be under a lot of shear stress versus axial load or compressive stress. Okay, and then you have saddle joints. So think of a equestrian, somebody sitting on a saddle, that shape, okay? So a saddle has this and then this, right, where the person sits. So a saddle joint is two articulations or the sides of the joint that allow this movement and this movement, but they're not going to allow rotation, okay? They'll bump up on the sides of the saddle joint. So all of these different joints are in certain parts of the body for certain reasons. Or maybe the body does what it does because the certain joints are in certain spots. I guess we'll never know. But the point is, saddle joint is mostly seen in the base of the thumb, and then there's one in the subtalar joint in the foot. Okay, and they only allow certain types of movement. Then you have joints that are there. They're technically a joint, but they don't really allow a lot of movement. You have a bunch in your skull. The suture lines of your skull are joints. So they probably allow a little bit of swelling if necessary. I'm sure this has evolved over time for some sort of life-saving purpose. And then you have some in your manubrium where the collarbone connects to the manubrium in your chest. Okay, and then some of the other joints in your body are like this, but synarthrosis or a joint with no movement is really just there, I think, just in case, I guess, to allow swelling and if there has to be some sort of force dissipation. Because remember, if you don't have a joint, the force has to go somewhere else. So it's either going to break a bone or damage structure around it. With a joint, force can be dissipated through movement. And then you have the amphiarthrosis. So I do a lot of foot and ankle surgery, very complex foot and ankle surgery. And one of the things we deal with a lot are syndesmosis injuries. You may know this when you watch football when the guys get high ankle sprains. So a high ankle sprain is damage to this type of a joint, an amphiarthrosis, where the bones are actually held very tightly together by ligaments. And if the ligaments disrupt, the joint is disrupted and allows ankle collapse. So here you can see in this image, the syndesmosis is comprised of the fibula with an articulation with the tibia. There's this little hollow groove that the fibula sits in called the incisura, and on all around it are strong ligaments. And when certain ligaments disrupt, it allows the ankle to open, book, or twist, or whatever. But the function of the syndesmosis in your body is to allow the ability when you walk for your leg to go over the foot. The front of the talus is wider than the back of the talus in your foot. And so when you're standing, if you were going to try to dorsiflex or bring the toes up, the front of the talus would not allow that, except that the syndesmosis does allow a little bit of rotation of the fibula and lets that come in, but keeps the ankle still very tight, very conforming, and very locked in. The ankle is one of the most stable joints in the body. And this is one of the reasons. Also, your pubic symphysis has one of these types of joints. The pubic symphysis, because of the hormone of relaxin, will actually lengthen, and that joint will become looser in women that are pregnant when they get close to the point of childbirth. So the body has amazing synergies and amazing communications, and just the complexity of all of these joints and how they work in various situations is pretty amazing, and, I hope that you agree. The sacroiliac joint, okay, you may know somebody that is getting a SI joint fusion or an SI joint injection. These are super trendy right now, they're very lucrative. You can do a sacroiliac, percutaneously, which meaning the pain doctors can do them now, not just surgeons. But think about this. Most of us after the age of 55, our joint is already fused naturally. That's just the way it goes, the design of that feature. And even when it's not fused, there's really only 3 millimeters of motion in flexion extension. Axial rotation, there's 1.5 millimeters of motion, and then lateral bending less than a millimeter. So there's hardly any motion in this joint to begin with. And then most of us is completely immobile after 55. So I'm not quite sure what fusions of this joint are accomplishing, uh, but they're being done at a rapid rate. So think about that if you've been offered one. All right, next. Not quite sure what. Um, oh, well, I think they're doing it because it's a new procedure to offer for quote unquote pain. But there's so many things backed by the SI joint that can contribute to pain in that area. In my opinion, the only way to really truly document that that's a painful joint is with a positive SPECT scan, which is the combination of a nuclear medicine study with a CT scan, or a very well done evidence based diagnostic medial branch block, which is rarely done in practice. Um, I personally would not recommend an SI joint fusion, but I know a lot of guys do for a lot of people. All right, so what is cartilage? Now remember I told you cartilage is part of the joint. It is the substance that coats the surface of the end of a bone, then it coats the surface of the end of the other bone. There's the lubricating fluid between, and then they can move on each other because cartilage is one of the lowest friction surfaces known to man. Okay, so it's a low friction surface between the bones, and it is designed to handle the forces of both shear and impact and the axial load. And it does this because there's various layers to the cartilage. There's a superficial layer, a middle layer, a deep layer. Then there's the attachment to the bone. Again, we've already talked about lubricating fluid. That the layers of the cartilage are formed of both chondrocytes, which are the cells, collagen, which is the main protein, and then the extracellular matrix. The extracellular matrix is not talked about enough. This is probably the most important part of cartilage, tendons, ligaments, bones, fascia, et cetera, et cetera. This is what really defines form and function is what proteins the extracellular matrix makes and when. What is the water content of it? How is it organized? It changes material to material. But pretty much all connective tissues have an extracellular matrix. And when that goes south, that is when you start having achy joints and painful joints. This is showing you an awesome picture of this is a very highly magnified electron micrograph of a cell, an active chondrocyte. You can see the nucleus, you can see little pockets of glycogen, which is how the chondrocyte maintains a fuel source. So glycogen is a storage form of glucose. It breaks down, goes into the mitochondria. ATP is produced and the chondrocyte can do the function it needs to do to repair itself, to produce more extracellular matrix, what have you. And then the endoplasmic reticulum is where proteins are made, which are highly important to the function of collagen as well. And then that bottom one shows you sort of the three-dimensional nature of how the collagen fibers all wind together to give you the ability to exist in space. So the bright pink shot is a normal cartilage surface, and then the lighter pink or more salmon color on the right is early arthritis. So you can see the dots with the little darker dots in it, they almost look like little eyeballs. Those are the chondrocytes. So up top, they're a little bit more lined up, they're flatter and they're parallel. As you go deeper in cartilage, they become more pillar-like and fatter, and that's normal cartilage. Abnormal cartilage, it just kind of goes all over the place. There is no organization. The extracellular matrix is not organizing things anymore. The surface becomes fibrillated. When you have that fibrillated surface, it's obviously not as smooth. The friction increases and it can't handle shear stress as much. So one of the functions of chondrocytes and all the stuff I'm going to teach you is to maintain this shape of the cartilage, to maintain that smooth top, and that involves the ability to repair. For years, we've been taught cartilage can't repair itself. It doesn't have nerves, it doesn't have blood, which is true, and it doesn't have a lymph system, also true. It receives its nutrition by way of the synovial fluid, water seeping in and out, and also because the extracellular matrix has the ability to communicate between levels and to tell the chondrocyte when certain proteins need to be fixed, when DNA needs to be turned on and off. So cartilage, in fact, more recent studies have shown, does have the ability to repair itself and create new cartilage and fix the extracellular matrix. So all hope is not lost as we've traditionally been taught. Um, the dispersed proteoglycan in cartilage, proteoglycan is a substance that allows for compressive force. And then there's other substances we're about to talk, like aggrecan and the different types of cartilage. Collagen, I mean. Collagen allows you to withstand tensile forces a lot, but if it's put in a different form and in a different shape, it lets you handle compression. If it's parallel, like on the surface and lined up in bundles, it lets you handle shear. So again, it's not just the material, it's how the material is put down and what's in the extracellular matrix that matters. The question is, how do you repair cartilage after 50? I'm going to get into it. We're going to talk about it. And if I don't cover it enough, ask the question again and I'll get whatever I didn't cover, we'll talk about.
Also, the same lady asked about
Osteopenia? What's the question? Somebody's asking about bone health. They want to know what to do about osteopenia. That's a whole nother conversation or topic, but generally osteopenia means that you are not indicated for an osteoporosis drug yet, but you should be on vitamin D3 and calcium. And then also resistance exercise actually helps bone mass come back. So weightlifting, mostly. And then we'll talk about, at the end of this talk, different supplements that help cartilage kind of get better. And a lot of the same ones work on bone because, again, it's all connective tissue. Yeah, we're going to talk about supplements that are of potential help to you as we get into the treatment and prevention section of this. Okay, so the extracellular matrix, again, not talked about enough. Many of you may not have even heard of it, but it's probably the most important part. It is 90% of the tissue of a joint, particularly of cartilage, okay? Chondrocytes are really only 5 to 10%. The chondrocytes are actually the cartilage cells. So the extracellular matrix is this like gelatinous substance in which the cells exist and where a lot of the fibrils of the cartilage are laid down and where a lot of the communication happens. This picture shows you a chondrocyte, that's the CH part. Around that is a pericellular matrix. Then there's usually an interterritorial matrix and a territorial matrix. So there's even different grades or levels of extracellular matrix that pertain to how close it is to the cell versus between cells. So cartilage is mostly what's called type 2 cartilage. There are a number of types. It is also associated with type 11 and type 9 cartilage. Bone is really type 1 collagen, okay? So sorry, this is type 2 cartilage. It's really meant to say type 2 collagen is the main component of cartilage and is found in the extracellular matrix. How this works is collagen is just protein, right? That's why you hear about people taking collagen to help their joint and they eat bone broth. So when you make a bone broth and you boil a bone for a long time, you're basically breaking down the structure into just the collagen, which is effectively just a string of amino acids. So the amino acids attach to each other and then they braid themselves. And this is done because extracellular matrix is able to provide communication and tell it how to do it. So you get a triple helix or a braid, think of a French braid in a little girl's hair. This happens with the collagen bundles, and then that gives you tensile resistance ability. And then if it's organized in more of a disorganized way, it can have a little bit of crumple ability, which helps to distribute force. Or if it's lined up in big pillars packed together, it can handle axial load, like when you're standing up. So the triple helix form the fibrils of collagen, which then eventually become cartilage. Again, they're parallel to each other on the surface where the bones move on each other to resist shear. They're perpendicular in the deep cartilage to resist the weight of standing or to help resist gravity. And the middle zone, it's a little bit less organized, and that's by design. That form allows any impact on the superficial surface to crumple and then not affect the deeper so much. And then this allows the body time and ability to repair later, which typically happens when you're asleep, FYI. We're going to get into that. And then the other proteins that are important are the sulfated proteoglycan allows for axial compression and aggrecan. Aggrecan is hugely important, and we're going to talk about that a little bit more. Aggrecan holds a negative charge, which lets it hold on to water and sodium. So if you don't have enough aggrecan in your connective tissue, particularly your cartilage, it gets dried out and brittle, which makes it more prone to daily stresses. But more importantly, water is the primary way cartilage receives nutrition and the primary way communication happens in cartilage. So your extracellular matrix has to have a certain level of water to be able to distribute messages around to make sure that the chondrocytes are behaving normally. So aggrecan is very important in this. So aggrecan plus the collagen will give your cartilage its mechanical properties. So without a significant amount of water, you can't withstand the compression that you need during life. And you also, without the aggrecan and the collagen working together, can't handle shear stresses or twisting stresses, certainly not impact. Okay, and then you've got other proteins like perlecan that hold growth factors. So there's proteins hanging out in a little pack of growth factors hanging around waiting for a message from the extracellular matrix to repair something. All of this works together and it needs to be kept healthy with a good diet, a good sleep schedule, things like that, low stress, there's not a lot of cortisol going on, and then your body will have a better ability to heal and repair. And these pictures are just kind of showing you the complex nature of what the extracellular matrix looks like as it pertains to aggrecan, which is the bottom right structure. It almost looks like the skeleton of a bacteria is how I think of that. But that's really a molecule of aggrecan in an electron micrograph. And then the picture above it is showing you how the collagen fibrils, those triple helix braids, lay themselves out in the different layers of the cartilage. So you can see it's parallel and flat on the superficial layer. The middle is a little bit more disorganized and sort of all over the place. And then the deeper is more like pillars, okay? So think of a building. The pillars support the weight, right? The roof on the top of the building is not, it's more like a parallel arrangement that allows things to slide off of it. So again, remember we talked about the pericellular matrix that surrounds a chondrocyte? Then there's the territorial matrix, and then there's the interterritorial matrix. All of it is different, the interterritorial matrix being the biggest component of your extracellular matrix. The pericellular matrix is only 3 to 5 micrometers. It's so small, I can't even imagine it. That is around each chondrocyte. There's no fibrillar cartilage in that. It is really more there to cushion and protect the chondrocyte from the forces around it. So it is not meant to handle shear stress, but rather compressive load, and really just to provide sort of a almost like an amniotic sac around the chondrocyte. Think of it that way. And then there's type 4 collagen and proteoglycans in there, and the perlecan. Remember, the perlecan is holding the growth factors. Then there's another protein called decorin. Decorin is hugely important in communication in the extracellular matrix to tell fibers how to line themselves up to handle force vectors. Without enough decorin, you get a very unorganized, mechanically insufficient type of connective tissue. So you need enough decorin in your tendons and ligaments to make them tensile and handle stress. Same thing in the cartilage to get it to line up and behave properly. So there is what's called mechanoregulation. Your body responds to the forces that are applied to it and will create a material that handles that force. And the extracellular component is vastly important in this. Okay. So I'm just going to give you an example in the business world of medicine of why this basic science, which sounds perhaps a bit technical, maybe it's boring, but it's really not. This is the fundamental science that the drug companies are looking at to make drugs to treat arthritis. To date, there is no what we call disease-modifying osteoarthritic drug. There's no cure for arthritis. The only cure for arthritis that we have is to actually remove a joint and replace it with metal and plastic. So people continue to try to make a drug that will modify the effects of osteoarthritis. We have them for rheumatoid, we have them for lupus. But right now, there's work being done following the basic science of what I just told you. And I'm just giving you one example. So remember, cartilage is formed of chondrocytes and extracellular matrix. The extracellular matrix, the pieces of it are the components, and their arrangement determines the function. When the extracellular matrix fails, or the components aren't put in the right place at the right time, or not the right amount of them, and there's not enough water, that's when you get joint deterioration and arthritis. And then which means your poor joint health is directly related to extracellular matrix health. What the basic science has found is that fibroblast growth factor receptor number 3, so this is the third described receptor for fibroblast growth factor, is the most important in terms of the repair capacity of the extracellular matrix. And they found that through elimination studies and knockout gene studies with mice, et cetera. So next slide. So just remember that FGFR, fibroblast growth receptor 3, is very important for the ability to repair cartilage that is deteriorating or damaged. So sprifermin is a recombinant FGF18 molecule, which is the ligand or the key that goes into the lock of the FGF3 receptor. So sprifermin is being made by a drug company to be tested for fixing damaged joints. It induces hyaline cartilage formation because it triggers that FGFR3 receptor to communicate to chondrocytes to go into a repair and remodel phase. Okay, so when you give somebody this particular protein, they have more chondrocytes and they have more extracellular matrix being produced. They've done a 1-year placebo-controlled proof of concept trial, and it did show dose-dependent effects. With drug research, if you don't have a dose-dependent effect, that usually means it's not the drug doing anything. Because if a drug is really making a change or a change in your body, more of it should do more and less should do less. So this did show that. Then they did a phase 2 safety trial for the FDA, and they showed there were no adverse events. And they did this in people between the age of 40 and 85 who already had moderate arthritis. So that KL grade 2 to 3, that's the Kelgan-Lawrence classification of joint arthritis. It's from 0 to 4. 2 to 3 is kind of moderate arthritis. Their joint space was about 2.5 millimeters. For the 5-year phase 2 trial of giving people injections of this particular protein, no side effects, and they felt that they had better chondrocytes and better extracellular matrix, meaning that the cartilage thickness got thicker. So it actually worked in terms of growing more cartilage and better cartilage. Next. No. Okay, so sprifermin. The interesting thing was, so you think, oh, great, wonderful. But this is just like all of the failed Alzheimer's drugs that target the amyloid protein. Uh, to date, most Alzheimer's drugs, with a few recent exceptions, even when they reduce the amyloid protein, have not changed the clinical picture. Sprifermin seemed to have that problem too in some of the trials. So although it made the cartilage thicker and it grew more extracellular matrix, there was no clinical response that was significant versus placebo, at least at the doses they did and the way they were doing it. There was a treatment effect seen on the lateral cartilage, but not the medial cartilage, being the outside of the joint, not the inside of the joint. But they had total knee arthroplasties occur in the placebo group, or the group that got no drug, they got the placebo. And then they had total knee arthroplasties happen in the group that got a low dose of sprifermin. But in the group that got high doses of sprifermin, there were no total knees. So the knee joint was maintained in terms of its functional integrity enough that that group, at least during the period of this trial, did not need a total knee arthroplasty, which is when you remove the joint and replace it with metal plastic. So the important thing to know is that now they've found a type of a patient that they think is going to have a good clinical response, meaning less pain, better function, no swelling, et cetera, as opposed to just seeing more cartilage on an MRI. But this is important. This is one of the first disease-modifying osteoarthritic drugs that has gone through and is now in a phase 3 trial. And this is where it's all going in terms of orthopedic care. And everybody's looking at the basic science. This directly affects the extracellular matrix and importantly affects the receptor that is integral to the extracellular matrix ability to repair itself. So you have that ability in your body now. It just needs to be amplified. And this is a drug that does that. I'm going to tell you natural ways you could potentially amplify, or at least it is my hope that that would amplify it to the degree that you need to avoid a total knee arthroplasty as well. Or any joint replacement, really. Okay, so sprifermin is one. We talked about that. Recombinant fibroblast growth factor 18, which is again just the key that goes into the receptor of FGFR3. FGFR3 we know is chondroprotective, and gene studies, so when they look at the genome of large groups of people, they have noted in some studies that people with low levels of the FGFR3 gene seem to be more prone to arthritis. So there are some people that have a genetic limited ability for self-repair and self-restoration. In this study, just so you know, it was an injection. They injected into the knee multiple times, over the time period of the study. It was developed by Merck, but then was licensed to a smaller drug company called TrialSpark. And then the Journal of the American Medical Association published the phase 2 results that we talked about. And now they're gone on to phase 3 studies. So this is not on the market yet, but I think a lot of people are hoping it's going to make it to market. Problem with this drug, like the problem with most drugs, is lifetime injections will probably be needed because when you're not giving it, the cartilage reverts back to its old state of deterioration and limited self-repair capacity, at least in the studies that we've seen so far. Okay, so again, your joint health is dependent on the health of your extracellular matrix of your connective tissues, cartilage, synovial, the tendons and ligaments around the joint, etc. The key pathologic feature of arthritis is the degradation of type 2 cartilage. It should have said type, it's TY, I don't know, it's a type. The degradation or deterioration of type 2 collagen and aggrecan is what makes arthritis happen. And you already know the importance of collagen for tensile force dissipation as well as axial load and crumple. And you know the importance of aggrecan for bringing in fluid and helping with the communication functions of the extracellular matrix, as well as the mechanical properties of the cartilage. The discovery of this particular protein called adamant, is what I call it in my head, ADAMT, that is the responsible enzyme for the destruction of the protein. What this particular protein does is it actually chews up and damages extracellular matrix proteins. When they bred rats that did not have the gene to make this particular protein, cartilage was protected even with forced trauma, meaning forced fractures, okay? Those rats seem to not get osteoarthritis. So this is called a disintegrin and metalloproteinase with thrombospondin motif. So obviously you would call that ADAMT. We always love our acronyms, right? The important thing for you to know is it's a metalloproteinase. Metalloproteinases are heavily involved in the damage of cartilage along with other protein-based connective tissue structures. So that is the key pathologic feature of arthritis, which is really like a cellular function and is really because of things like chronic inflammation and oxidative stress, lifestyle problems, not so much the wear and tear you've been taught in the past, and I have too. So the catabolic pathways, meaning the pathways in your body where damaged tissue is chewed up and gotten rid of so that new tissue could be put in and remodeled, they're highly mechanically sensitive. So the ability to sense and withstand shear and axial load, and then the ability of the decorin and the perlecan to talk to each other in the extracellular matrix based on the shear and the axial load they feel is very important in terms of repairing cartilage or allowing this metalloproteinase to just destroy things. Obviously, you want to control this metalloproteinase as best you can. Okay, so why do we care? Why do we even care about joint health? Well, obviously, it impacts your overall well-being and your quality of life. And when there's an impact to your quality of life, there's a psychosocial component. So people with chronic pain of their joints tend to have muscle fatigue. They tend to get depressed. They start to socially isolate. All of this imparts a poor quality of life, which then impacts your health span and your longevity. So the human body feels the absolute best when it's moving, when it can move, and when it does move. This is why movement is key to most health outcomes. Muscle mass is key to most health outcomes, as is bone health. So without a highly functioning or at least a decently functioning joint, you're not going to be able to engage in the movement and the existence in space that really contributes to a higher quality of life. Hold on. The question is, what are my feelings on stem cell injections? Just so you know, the FDA is strongly against this. And in this country, it's really available only in a very limited fashion. The only way I can give you stem cells is if I enroll you in a clinical trial or if I take it from your own bone marrow with an invasive procedure, and then process it at the same time in the same day and inject it right back into your body. But I think stem cells are probably the future. There's no doubt that they are miraculous and work amazingly well. But right now, the FDA does not want us to really um, discuss that, if you will. So probably leave that out of this conversation. But I have used stem cells, particularly from bone marrow, for people for years in orthopedics. We've used it, and there is a ton of evidence behind it. Sadly, right now, you really almost have to fly to Panama or Nicaragua or somewhere if you really want to get stem cell treatment. But there is a lot of robust information and basic science that supports it, and ongoing work is happening. I have done stem cells and still do for people, but because it's so invasive and painful, I try to find other ways to naturally get the cartilage to sort of regain those repair capacities, just to avoid, drilling a hole in bone to get somebody's own bone marrow.
Any,
Another question.
just
Okay.
any opinion on gluten and inflammation?
Gluten.
I would say,
Okay, so the question is do I have an opinion on gluten and inflammation? Yeah, I'm going to talk about oxidative stress and inflammation and different supplements that help. Some people do develop an inflammatory response to the protein of gluten. Other people don't. There's actually a very highly specific way to test for that particular antibody, and it's very rare to actually have a response to that. On the other hand, gluten is typically involved in carbohydrate products, which are generally ultra processed in this country. So usually when you're eating gluten, you're eating a highly processed food product that's usually replete with simple sugars. So of course it's going to induce inflammation. All right. There's a bigger picture with joint health. You may have achy, creaky joints. Your joints may sound like a machine gun in the morning. You may find when you get up out of a chair after sitting still for a long time or taking a long drive that you can barely unfold your hip because it's so stiff. But it's a bigger problem worldwide. 15% of the global population over the age of 30 has osteoarthritis. We think there's going to be a billion people with this problem by the year 2050. Now, I know we hear huge numbers tossed around all the time, but a billion, if you really think about a billion, that is a tremendous number of people running around with arthritis. In 2019, there were 528 million people with arthritis, which was a 113% increase in the prevalence of arthritis since just 1990. Now, think about that. What is that? 20 years? Just about? Am I getting my math right? 30 years? So over a space 20 to 30 years, 113% increase in osteoarthritis, but yet all of our activity levels have gone down. Our medications presumably have gotten better, and our treatments in terms of orthopedic have improved. These numbers are not computing in my head. So I think there's a bigger picture we're missing here. The most common joints to be reported as affected by arthritis are the knee, the hip, the hand. Females seem to complain about the symptoms of arthritis more than men. So the prevalence seems higher in females than men. It's about a 60-40 ratio rather than 50-50. About 20.9% of US adult women have osteoarthritis. That's 1 out of 5. And then 16.3% of the men. Veterans, I'm a veteran, I'm a female, I'm in the older age group. So you would think I'd have arthritis, but I don't, but I'm in all the risk groups. Veterans seem to have it more than non-veterans. And the importance is it's a huge economic burden, not to mention the quality of life and depression things we just talked about. There's a loss of productivity in the workforce. There's huge amounts of costs associated with this and a lot of time and effort spent in medical care. Again, we still have no cure. And then there's heightened amounts of what are called transfer payments because this is one of the most common reasons for people to go on disability and stop working. So even the ones that are still working aren't as productive. And then a lot of people just stop working because of the debilitating effects in terms of the pain and stiffness and the loss of function with osteoarthritis. So by 2050, 78 million Americans are going to have this problem. And again, a billion worldwide. So we got to get a handle on this. And I don't think lifetime injections of recombinant proteins is really the best answer. I think we can do it a little bit more holistically and naturally. And then, God forbid, if you need one of those injections, you'll get it. It should be more effective.
What are your thoughts?
Oh my gosh. All right, another sorry, I keep getting hit with questions, which are great. This question is, what are my thoughts on PRP for joint injections? So we just talked about stem cells and how I like them, but what I've really turned to, because the FDA has kind of shut down that entire industry and most people don't want me to drill a hole in their iliac crest with their bone marrow. What I've turned to is injections of platelet-rich plasma, which is PRP, and I'll often combine it with injections of hyaluronic acid, which is the main lubricating fluid in the joint, synovial fluid, right? Platelet-rich plasma is when we take your blood in clinic. Okay, we draw it in clinic, so it's an in-office procedure, pretty painless. Take it to a particular centrifuge with a particular type of device. We spin it, and that separates out the red cells from the white cells. And what you end up with is a concentrated little bit of liquid that is filled with platelets. Okay, and you can even separate out the white blood cells like the leukocytes, and just have platelets and plasma. Then you inject the platelets directly into the joint, and this is a very highly concentrated amount of them. And then what you end up doing is just putting a bunch of growth factors and protein forming catalysts into the joint, again, to help the extracellular matrix function. So I do PRP for a lot of patients and I love it. And it's a very simple in office procedure that's way cheaper than any stem cell procedure. PRP is not covered by any insurance that I'm aware of, particularly in my state of Louisiana. But we do it for like 400 or 500 bucks. I've seen it around town for as high as 2 or 3 thousand, and I've seen it around the country for as high as 20,000. Basically, it's a simple procedure where you draw blood, spin it, separate out the platelets, and put them back into whatever connective tissue responds best to it. I'm a huge fan. It works very, very well. All right. So the causes of joint problem have traditionally been thought of as age. Oh, you're getting older. Your joints are going to fall apart. It is what it is. Injury, oh, you fell. Your joints are falling apart. It is what it is. Or arthritis. Okay. And everybody was always told arthritis is because of age and wear and tear. Those are the traditional thoughts. I would like you to get rid of those thoughts. The real reasons people get arthritis or osteoarthritis is a lack of activity. So there's none of that mechanical stimulation to tell your cartilage to repair itself. You lose muscle mass, which is hugely important for overall connective tissue health, and you lose bone mass, which is hugely important not just for brain health, but overall connective tissue health. People that are inactive have more arthritis than people that aren't. So lack of activity is a real reason. And what happens with age, have you noticed? You start to get less and less active as you get busier and busier with work and family life and errands and events you have to go to and this and that, whatever. You don't have that playtime. You don't go outside and run around. You're not working out. So a lot of what we think of as aging is really diminished activity. So you could prevent a lot of aging just by staying active. And then lifestyle. So the diet, so depleting yourself of essential micronutrients and minerals that are required by those proteins we talked about in the extracellular matrix to do the repair and restoration functionality, and then lack of the amino acids that are needed to make proper cartilage, lack of the cofactors to cross-link the amino acids to make a strong braided structure, and then loading your bodies with toxins from air pollution, water pollution, what have you. And then, of course, the age-old enemies of oxidative stress, which is free radical damage, and chronic low-grade inflammation. I'm not talking about the inflammation of an acute injury where your joint swells up, it gets red and swollen, and then that just goes away. That is a normal function of the immune system. I'm talking about the chronic low-grade inflammation brought about by mental stress, poor sleep, um, having excess energy depositions around your body that constantly produce inflammation, and then the toxins, the response to the toxins. So again, all of these are modifiable or preventable. And then you have a much better chance of having very healthy joints, cartilage. So again, the causes of joint problems. The bottom is really probably what is going on. So extracellular matrix gets degraded and broken. Cellular senescence, this is when the chondrocytes just stop they stop living, they just kind of sit there and put out bad proteins instead of responding to the information imparted to them by the pericellular matrix. So they become zombie cells that send out damage associated molecular patterns that cause the immune system to send in metalloproteinases, which we already talked about, which then degrade the cartilage. Dedifferentiation, so some cells, like stem cells that could become chondrocytes, don't anymore. And then you get ossification inside of the cartilage, like it becomes bone instead of cartilage because communication is so messed up. Apoptosis, which is cell death, and then fibrosis, which is sort of, you don't get smooth, beautiful hyaline cartilage, which is what we think of as joint cartilage, but rather it gets replaced with this subset of cartilage that's just not as good. And then, of course, above, you've got aging, which is really not a big believer in practicing ageism. So I don't really blame anything on aging. Most of the effects of aging, again, are because of lack of activity and a poor lifestyle. Obesity, which is a modifiable risk factor to make your joints work better. The problem with storing a ton of energy in the form of fat on your body is that they produce stuff called adipokines. And adipokines are highly inflammatory proteins that induce inflammation throughout the body. And then, of course, you're going to have insulin resistance, which really damages connective tissue, particularly joints. Excessive loading. If your cartilage is built to handle the load, that doesn't matter so much. But if it's not, or if the extracellular matrix is not lining up those pillars in the deep layer properly, then yeah, excessive loading might matter. Metabolic syndrome, which is insulin resistance, we've talked about how damaging that is in previous talks. Genetic predisposition, remember I told you in the gene studies, the people that have less production of FGFR3 seem to be more prone to arthritis. That's just one example. And then your gender and hormone profile. So how much thyroid hormone do you have? What's your estrogen levels? What's your testosterone? What's your growth hormone? All of this plays into your cartilage and joint health. So it is way more complicated than just, oh, I happen to be on this earth for 50 years, so I must have osteoarthritis. Or, oh, I walk a lot at work, so I must have osteoarthritis. None of that is school thinking. We need to start thinking a little bit more realistically about what the real fundamental problems are. Chronic inflammation is the enemy, oxidative stress is the enemy, and those cause inability to self-repair. And the self-repair capacity, not only do you have to have no chronic inflammation and no oxidative stress or low, but you also have to give your body the time to repair. When does that happen? At night when you're asleep, and especially if you're asleep in a fasted state. So the circadian rhythm is massively important to cartilage and joint health. And it is not talked about in orthopedic literature hardly at all. More and more, but much more work needs to be done. But I talk about this in the book I told you about in the beginning. The circadian rhythm, I think, is going to be one of the keys to maintaining your body and your health and to feel good and to be able to move in space and do the things that you want to do as you spend more time on the planet Earth. So we have some common name joint disorders you've probably heard of: rheumatoid arthritis, lupus, psoriatic arthritis, osteoarthritis, which is what I'm talking about today, septic arthritis, gout. What is common in all of these is that they all increase inflammation within the synovial structure of the joint. They all have increased oxidative stress, and then they all have terrible mitochondrial function within the chondrocytes. So there's low levels of energy, low levels of protein production, and inability to withstand things like insulin onslaughts. So a lot of the cells will become insulin resistant. And then when you have all of these problems, you get those senescent cells that send out damage signals, and you get unrepaired tissue that sends out damage signals. And when that happens, then you start to self-attack. So when your molecules send out these damage signals, the immune system picks that up and comes in with, guess what? Metalloproteinases degrade things further, try to clean it up, but there's no repair capacity because of chondrocytes. Mitochondria aren't working. Extracellular matrix is dysfunctional, so there's no communication. It's like just a terrible army trying to fight a war. It's just not going to happen. So your goals, if you want to function, and have a really healthy joints, is to figure out ways to manage those commonalities. So, most people believe in their heart of hearts that it's really just a wear and tear and age problem. But is wear and tear and is bone on bone, which has to be the name of the book, by the way, a real thing? And I'm here to tell you it's probably not as real as you think it is. So people have actually gone back and looked at skeletons of people in prehistoric and medieval times, like just way back in the past. Now, and I know that we are extremely inactive in modern American society relative to our prehistoric relatives, right? And even relative to people in the 1950s and 1960s. So work used to be much more physical. A lot of people lived on farms. Factories didn't have any of these methods or ways to minimize force on joints and to minimize how much you walk at work. So we're actually way more inactive now than ever. Most of us just sit all day, frankly. But the prevalence of osteoarthritis is much greater. Remember, I told you it's risen like 113% over the past few decades? Well, if we're way less active, okay, and even our athletes are way less active probably than the athletes of yore. If you are way less active now than you were relative to if you lived in 1950 or let's say a billion years ago or 100 million years ago, why do we have more arthritis now? The skeletons of these prehistoric populations did not show the level of joint deterioration that we. There's less manual labor. There's less need to walk anywhere. You don't have to go hunt your own food. You don't have to go farm. Most of us aren't going out milking the cow in the morning to get the food for the day, things like that. But yet we have more arthritis. So can it really be a wear and tear thing? Fundamentally, no. Activity and exercise are protective of your joints. So again, the CDC recommends activity as a primary treatment for arthritis, as do most respectable societies in the orthopedic and rheumatologic world. Activity is your best way not just to prevent, but to treat symptoms of osteoarthritis. Exercise is protective of joints. Movement is protective of joints. Inactivity, sitting around doing nothing, forces your joints to fall apart and degrade. And you know why now, because you're not getting that mechanical input, the hormonal response from muscle and bone to tell your cartilage how to behave and how to form itself, where to put certain proteins, how to line them up. All that goes away when we're inactive. So the joints deteriorate. So just remember, there's a lower incidence of osteoarthritis in people that are active than in people that are sedentary. So it just fundamentally cannot be a wear and tear problem. All right. So again, physical inactivity. So if you're just sitting on the couch all day or you have a desk job and you never get up and move around, you are down regulating your own production of aggrecan. I already told you how important aggrecan is. And then you are also forcing your cartilage to become atrophic or atrophy. It gets smaller. Just like anything that's not used. You don't use a muscle, it gets smaller. You don't use bone, it gets osteopenic, to the lady's point in the beginning of the talk. You don't go out in the sun, you don't get enough vitamin D3 and your melanin production goes down. So the human body responds to how it's used and the loads that are imparted upon it. And if you're not telling the body that it needs to keep your cartilage healthy, it is not going to keep your cartilage healthy. Cartilage responds to mechanical forces, and then more aggrecan is made when there is the receptors that respond to mechanical load when they sense load and movement. That's when you're laying down proteoglycan, aggrecan, and getting your extracellular matrix healthy. So a sedentary lifestyle, i.e. the modern lifestyle, is just not conducive to normal healthy cartilage. They don't go together. You have to be active and move to get your cartilage to go into self-repair and even sense what is happening around it, organize everything so that you have that form, function, beauty that is the human body. So the lack of repair of long-lived type 2 collagen is thought to be a cause of bad joint health. Remember I told you in the beginning, we used to think that once you form your cartilage, it can't ever repair itself, and now we know that's not true. Well, collagen tends to stay around in the body for a very long time. So the only way that it's going to not fall apart is if you maintain it. Think of this like the B-52 bomber. That thing is still in service, and it was first made 60 years ago. Most of the B-52 bombers flying around are 60, 70, 80 years old, something like that. My dad would know this better than me. But the reason they're still flying and they're still very useful to our military is because they're constantly maintained. So the same is true for you. Your physical body has to be maintained. And the lack of repair of your long-lived cartilage, the lack of production of aggrecan, the lack of communication in your extracellular matrix, all of this is going to compromise your joint function and joint health. So it is up to you and me to make sure that our body has everything it needs to self-repair, one of which is movement and activity. These are just images showing you damaged joints. The one on the bottom, that is what a lot of people will look at and say you're bone on bone. So you see in the medial, the inside part of the joint there, which is the left side of the bottom left picture. See how the joint space between the tibia and the femur is a little bit narrower than the joint space on the outside. That is when you've lost cartilage and meniscal tissue. This is somebody that's probably had a meniscal debridement and a knee arthroscopy probably we'll say 6 to 10 years before that x-ray was taken, and then the joint just falls apart when it doesn't have that natural structure. And then also, most meniscal tears are associated with the normal deterioration relative to chronic inflammation and oxidative stress. And then the picture to the right is a new high-tech imaging that has the ability to show areas of subchondral bone deficiency or cystic change. So that's when the structure of the bone itself becomes poor. And the bone is like the rebar, the superstructure on which the cartilage sits. So you have to have a good foundation. So bone health is hugely important to your joint health as well. Okay, we have a comment.
Lady's ridden a horse for 50 years, and she's heard what you said about wear and tear, but thought it was suspicious. Her right hip, her mounting hip, was much worse than her left hip. I mean, maybe her left hip is, maybe she's always compensating or something. I don't know. Interesting. You want to comment?
Somebody just made a comment that they've ridden horses their whole year and they noticed that their right hip, 50 years, they noticed that their right hip is worse, which I presume that means more painful than the left hip, and the right hip is the one they use to mount. So joint pain, if you've watched my talks before on like knee pain and stuff, the joint is not just the cartilage and the synovial lining, but it's also all the surrounding ligaments and tendons and joint capsule. And a lot of times, if any of that tissue gets contracted, it changes the biomechanical function of any one given joint. And then that has different mechanical load, I guess, which can induce some level of chronic low-grade inflammation. So like a lot of like golfers that are always twisting one way, one side will get contracted, one side will be too loose. It's probably the same for somebody that's always getting up on the right leg. Probably just need to do some counteracting exercises to do the opposite of that mounting motion. So like a lot of my people that are desk workers like this, I try to encourage them to do the opposite movement as many times a day as possible, just to stop that contractile nature of tight muscles that are always in the same position. That's why I think sometimes people have more symptomatic joints on one side or the other. It's really an imbalance of the muscular forces. So time and joint health, remember I told you how important sleeping is to cartilage repair capacity and tendon and ligament and connective tissue. The repair capacity is linked to these genes called clock genes. These have been discovered within the past 10, 15 years or so. These genes are found in the peripheral cells all throughout your body, and they are controlled by messages received from the brain and the gut relative to when light and dark happen or feeding and fasting happen. So when you're in the sleeping state at nighttime, certain signals are sent to the clock genes, and some will turn on, some will turn off based on what they're supposed to be doing. But they need that initial trigger of going to sleep and that message being sent by the brain to function. So the repair capacity of chondrocytes, tenocytes, fibrocytes, and extracellular matrix of your joints, your muscles and your bone, all of those are linked to clock genes, and we think, and they seem to work the best at night when you're asleep, which makes sense. Why would your body try to repair itself while you're using it? You know, it's the same like here in Louisiana, we have a lot of chemical plants and they get shut down for a certain time period, and that's when all the maintenance happens. Well, you can't do maintenance work on a plant while it's actively making a chemical. Same thing's true in your human body. You have to have downtime for the repair and restoration capacity. So of course this is going to happen during sleep. And then it's doubly enhanced if you're fasted. So most cells work best in terms of repair, restoration, and cleaning up bad parts of the cell, recycling what can be recycled, getting rid of what is not able to be recycled, and then repairing and remodeling. All that works best in a fasted state. So time-restricted eating, I think, is hugely important to your joint health. You need to have a certain time period where you're eating during the day, and it has to match the daylight or when you're awake. And then you should not be eating at the time period where you're supposed to be asleep and entering into that repair capacity. So the fasting turns off all of the signals from the gut, which also go to the clock genes. Remember I told you there's a gut and a brain signal. Those are the master clocks. So if you can coordinate those master clocks, then all of the peripheral clock genes are coordinated and you get much better repair at night. So super important to be active during the day. You're going to be inactive at night. You're going to be asleep and fasted. And that's when things are going to repair based on the signals they got when you were active during the day. Next slide. Okay. So nutrition. remember I told you chronic inflammation, oxidative stress? I mean, I sound like a dead horse that's getting beaten. I say this stuff over and over again, but you have to understand this. This is fundamental. Nutrition and joint health go hand in hand. Good nutrition means less oxidative stress, less chronic inflammation, better everything, particularly musculoskeletal system. So we found a much lower prevalence of osteoarthritis in the so-called blue zones. These are the areas where people live into their hundreds regularly and are very active in their older age. We've found a lower prevalence of osteoarthritis in most major studies of the Mediterranean diet. And then we found lower levels of osteoarthritis or musculoskeletal dysfunction in people that have higher levels of omega-3s in their system. So your diet and your weight strongly influence the rates of autoimmune and osteoarthritis. So autoimmune is even regulated by diet and lifestyle and weight. And remember, weight matters because of the insulin resistance, which affects how your cells function, and also because of those adipokines, those highly inflammatory proteins that attack everything, including your joints. Okay, so the Mediterranean diet, which is filled with the micronutrients all of those cells need and extracellular matrix needs, low in refined carbohydrates, like we talked about, low in added sugars, so there's less chance of insulin resistance. All of this is going to play into how your cartilage is able to function during the day and able to fix itself at night. So you have to give it the right fuel, and you can't subject it to insulin resistance, inflammation, and oxidative stress. This is why nutrition is so important to how your joint and your body feels. Somebody asked a question about the TRE, the time-restricted eating. Is it a 12-hour fast or more? 12 hours is a great place to start. So 8 a.m. to 8 p.m. You eat, that's your window. 8 p.m. to 8 a.m. you don't eat. Once you've mastered that, you can compress it a little bit. I don't think to date in the clinical studies where they've put people head to head that they've noticed much of a difference between a 10-hour eating window or an 8-hour eating window. I personally try to stay within a 10-hour window. So that means I'm not eating for 14 hours every day, and I try to match it with my circadian rhythm. But these studies are ongoing and happening now. I think 10 to 12, if you can do 12 and that you can't handle doing 10, that's fine, but 10 is probably better. But I can't say that 8 is probably better than 10 or that 6 is better than 8. We just don't know yet. All we know is you need to be fasted when you're asleep for all this stuff to work. And again, you are what you eat. So we've talked about this ad nauseum in other talks. You want a diet high in fiber because that helps your gut function better, which reduces gut inflammation and helps your gut make appropriate proteins for the body. You want a diet filled with micronutrients, things like zinc, vitamin C, the B vitamins, beta carotenes, all these little things that most of the American diet, which is 80% ultra processed, doesn't have. You want a diet that is filled with healthy, good meats that are grass finished, okay, and you don't want to eat them too often. You want a diet that has a lot of polyphenols and antioxidants. And then you want a diet that's high in omega-3 and then olive oils, which has monounsaturated and certain polyphenols that are also highly anti-inflammatory. So there's a reason I love the Mediterranean diet. A lot of doctors that are proponents of other types of diets, but we have just so much data on the Mediterranean diet and how great it is for people. And also it's approachable. It's easy to do relative to other types of diets. And it's fun and it's social and it's good. So I'm a big fan of the Mediterranean diet, but just bear in mind that's 9 servings of fruits and vegetables every day, which is a lot to do. So I also supplement because I don't have the time for that. I wish I did, but I just don't. All right, next. Okay, and even the Arthritis Foundation, one of the largest nonprofits that tries to find ways to manage arthritis, they even love the Mediterranean diet. So I think you should think about it. That's how I try to eat if at all possible. Nobody's perfect, of course. We're all going to have a little breakdown and eat something bad every now and then. But in general, if you can match up a Mediterranean diet with a time-restricted eating schedule, with a good sleep schedule, you are on your way to a better functioning body, better extracellular matrix, and the ability of your cartilage to repair itself, where you don't have to rely on lifetime's injections of drugs or surgery. Okay, sarcopenia, also massively important. We've already talked about movement, exercise. I've mentioned muscle a couple times. Stronger muscles are massively important to joint health. A study just came out, and there have been studies before that proved with MRI studies that bigger or presumably stronger thigh muscles helped prevent knee replacement surgery. So having a bigger, not big, I'm not talking Arnold Schwarzenegger big here, but having better quadriceps muscle, which is your thigh muscle that lets you kick a ball, lets you walk up a stair, lets you get out of a chair. The stronger thigh muscle prevents the need for total knee arthritis. So think about that. Just doing some wall sits every day, and you might be preventing the need for a total knee arthritis. When you lose muscle mass or get sarcopenia, you lose a lot of hormonal signals the muscle sends out. You lose strength. You lose the ability to shock absorb across joints. And then you lose that pull on the bone from the muscle, which makes the bone healthier. And you lose the proprioception, which is that neural interface between the muscle and the brain that lets you know where you are in space. You lose balance. Your joints start to become dysfunctional and mechanically not right, which contributes to, like, if you have a tight piece of collagen and you try to stretch it out, your body's going to feel that and may interpret it as pain. So muscle's hugely important. And muscle mass is independently associated with the prevalence of knee arthritis. So stronger people with more muscle seem to have less osteoarthritis, which you would think to yourself, how does that make sense? If you have more muscle, you must move more and you must weigh more, which means you're loading your joints more and there's more wear and tear. So wouldn't you have more arthritis? You would if you believed all that traditional teaching. But if you follow me and you believe the newer science and what the evidence really shows, movement and strength, even though muscle weighs a lot, is very protective of your joints. So being obese and having no muscle mass or sarcopenia, that is possibly the worst combination you can have. Because not only do you lack all of the beneficial aspects of muscle, but now you've got all of that extra energy formed in adipose, which you know of as fat, producing all of those adipokines on top of it. So you don't have the protective effects of the muscle on your cartilage, and you're self-attacking with a bunch of adipokines. So the people that are both obese and sarcopenic, they're the worse off, but you don't want to be either. You certainly don't want to be both. And then again, we already talked about decreased muscle mass in the leg is associated with more knee pain. And then mitochondrial dysfunction, which we've talked about, from chronic inflammation, oxidative stress, poor communication of the extracellular matrix, senescent chondrocytes, lack of a circadian rhythm, toxic overload. When your mitochondria, which is the energy powerhouse of the cells, fail, then you get sarcopenia, you get damaged cartilage, nothing works right, you can't fix anything because the cell's engine is kaput. So all of this plays into each other. You don't have to fix it all at once. You could just pick one thing and go with it. Get a good sleep schedule first, then incorporate it, time-restricted eating, then incorporate the Mediterranean diet. I go into this whole protocol at length in my book, Bone on Bone, that we talked about, but I'm just starting to give you some insight as to some of the science behind it. So aging and obesity, and remember, I don't practice ageism, but basically most people, because they become less active when they get older, have a lower metabolic rate, their mitochondria start to fall apart, they have less hormonal balance, I guess. And all of it is really linked to lifestyle things, in particular lack of muscle from lack of activity. And then a bunch of fat and become insulin resistant, that's another reason your mitochondria is not going to work. So it's very important to move, to get some muscle, and to sleep right. Okay, next.
Do you have any thoughts on BMI, and doesn't more muscle mass reduce BMI?
Yeah, somebody asked a good question about, do I have any thoughts about BMI, which is body mass index, and doesn't muscle mass increase BMI? Yes. So a lot of people are going away from BMI right now, actually, because of that reason. And also, like people that are sarcopenic, like the frail elderly people, have great BMIs, but that doesn't mean they're healthy. So BMI is kind of an old school way to classify obesity. You know, BMI of 40 or more was class 3. I think 30 to 40 is class 2, et cetera, et cetera. Now they're starting to think of different ways to categorize your level of insulin resistance and obesity. But you're right, BMI is still used because, of course, it's what you get to code for and the insurance companies look for. But most people in the longevity world and in like really hardcore science about insulin resistance and stuff aren't really looking at BMI anymore because of exactly what you said. So hold on one sec. What? Oh, water. Sorry, I get really dry when I'm talking this much. Probably I'm talking too much, huh? So what are the symptoms of joint problems? These are the people that I see in my clinic often. They come in, they tell me they're stiff, they're creaking, they've got pain, their joints swollen, they're weak, they have no balance, they can't get on the floor and play with their grandkids and get up again. They're scared to death of falling anywhere because they're scared they'll never get up, things like that. Or they have trouble going up and down stairs. They find they're always taking the elevator at work. If they're sitting at the desk and they try to get up at lunchtime, they can barely get out of the chair. So these are the symptoms that lead to that quality of life deficit I talked about. And then that goes on to things like depression and social isolation. So this is what I'm trying to get you help to treat yourself. Okay, so we've kind of sort of touched on some of this. This is all detailed in Bone on Bone, like I talked about in my protocol for you, but it really is, I like to think of it as common sense, kind of like what my parents told me growing up: go to bed early, eat right, things like that. Try to maintain your stress level, go be social, go play with your friends. So nutrition, exercise, sleep, circadian rhythm, and then I add in supplements because I find it very difficult to get the diet that really would be helpful because there's a lack of biodiversity in our food supply now. Everything's ultra processed, things like that. And then stress management and physical therapy is one of my mainstays of helping people get better naturally. Physical therapy is what I use to treat things like when the extracellular matrix has poor crosslinks and it's too stiff and thick. There's techniques to make that looser. There's ways to make nerves function better and glide better and move around joints better. There's ways to make your muscles balanced and work better, so that golfer and the horse rider, like we talked about before. Physical therapy can work on all of the different fascial interconnections. There's a connecting line from the bottom all the way to back of the ball. If it gets stiff or dysfunctional anywhere in that line, you'll feel it in other places when you're trying to do different things. So good physical therapy team like I have can really help you manage that. All of these are ways to handle bad joints and bad joint health yourself. You can get better and you can prevent things from happening. So nutrition, we've kind of touched on. Super duper important. I like the Mediterranean diet. I'm a big fan of that. That's what I am a proponent of. Filled with veggies and fruit, olive oil. Its main feature, I think, that's beneficial for you is that you try to avoid ultra-processed foods if at all possible. What is an ultra-processed food, you might be asking about? It's anything that doesn't exist in nature effectively, that was made in a factory, from deconstructed food that is then put together. Stuff is fortified or added back, and then it's put in a plastic bag or something. So like breakfast cereals, potato chips, bread. Most bread is ultra-processed. So really almost everything at the grocery store is ultra-processed. So just try to shop in the perimeter, right, where everything's fresh and whole. Complex whole carbohydrates are great for you because they're filled with fiber. Ultra-processed refined carbohydrates are terrible for you because they're not filled with fiber and they're ultra-processed. So whether or not either of them have gluten, to the other lady's point earlier, unless you have a true gluten allergy, is irrelevant. Probably what's really causing the problem is the ultra-processed nature of that carbohydrate. And then matching eating this beautiful Mediterranean diet pyramid to your sleep-wake cycle is going to be majorly beneficial to how your musculoskeletal system works. Exercise. I don't ever tell anybody exercise to lose weight. It doesn't work. We've talked about that in other talks before. Your body adapts to the level of activity and will just turn off certain functions and turn on other ones to conserve energy. Humans exist in this particular range of calorie use on a daily basis, whether you're a marathon runner or an office worker, whether you're a hunter-gatherer or sitting on a couch all day, it doesn't matter. So exercise, don't do it for losing weight. Do it to get strong, do it to get muscle, do it to get your bones healthier, do it to help your brain. Exercise helps prevent dementia, cognitive decline, and other neurodegenerative problems. It helps you avoid sarcopenia. Okay, and then we've talked about exercise before and the best prescription for it. About 30 minutes a day in zone 2, which means you're moving enough that you can talk to someone, but it's a little bit difficult. Okay, so there's that level of aerobic activity going on. 30 minutes a day for about 5 days a week is what's recommended. People used to believe that you had to do the 30 minutes all together. Nobody believes that anymore. Well, some people do, but the science shows that you can break it up. So you could do 3 10-minute sessions. You could do 6 5-minute sessions. You just need to get out and do something. And then, importantly, 2 to 3 days of resistance training. Why? Because muscle is so important to all of this.
Is walking considered to be weight resistant?
Is walking considered to be weight resistant? I would say yes, if you're not walking in water or on one of those gravity devices, because you're loading, you're fighting gravity. Is walking as good as like doing squats with a squat bar for resistance? Probably not. But is it much more approachable? You don't have to join a gym. You can do it with your friends. Yes. So walking is weight resistance. If you want to add a little bit more weight, wear a weight vest. There's different ways to add load to help you build muscle as you exercise. Walking, if you walk fast enough, will put you into zone 2 and give you a little bit of resistance. But I would suggest that you add a little bit of weightlifting on top of that. Sleep, we've talked about this. So the mechanical control, the biochemical control, all of these things that help your extracellular matrix work right, create those different zones, the pericellular matrix, the territorial matrix, the interterritorial matrix, help it lay down the collagen fibrils either in a parallel, crumpled up, or pillar type arrangement, help them cross-link properly. All of this happens at night, okay, while you're asleep. 7 to 9 hours is the recommendation for most human beings on this planet. And then the circadian rhythm matters. I call it a constant routine protocol. You need to go to bed more or less the same time every day, wake up more or less the same time every day, weekends and holidays included. Anytime you disrupt this, you're effectively putting your body into jet lag and everything falls apart and doesn't work right. So you need to get a consistent routine, and that routine and structure is going to train your body and train all of the clock genes when to work, how to work, and it's going to let them work. Being just all over the place is really linked to prevalence of osteoarthritis and other musculoskeletal problems. For instance, shift workers have a much higher incidence of osteoarthritis, cancer, other problems relative to people that don't work shifts. Why? Because their circadian rhythm has just been destroyed. So the circadian rhythm matters a ton. And then even more importantly, if you can match your gut feeding fasting clock to the brain's suprachiasmatic nucleus, which is what responds to UV rays from the sun, match the two, and then you're really in a good position to help yourself out. So you got to practice good sleep hygiene. Try to get on a schedule where you're not eating at night so you can enter into a fasted state, because that's when your body's repair capacity works the best. All right. So the circadian rhythm will influence the activity of your chondrocytes. So whether or not they're metabolically active, are they sending out signals to produce proteins? Are they making proteins? Are they repairing themselves? Are they telling the extracellular matrix what to do? It is important for the synthesis and degradation of the different components of cartilage that we've talked about, the proteoglycans, the aggregans, the perlicans, the collagens, okay? It turns on or turns off certain genes as needed. For instance, you might upregulate the NFKB gene, which is highly inflammatory, or you might rather upregulate the NRF gene, which is highly anti-inflammatory. And then you've got hormone oscillators. So cortisol linked with stress and being awake, highly inflammatory, okay? This is why you want to manage your cortisol. And then melatonin linked with sleep is extremely antioxidant. In fact, melatonin is one of the most antioxidant molecules we know about. And again, not to, beat a dead horse. No offense to the horse rider of before. Irregular sleep patterns will affect that repair and regeneration of your cartilage, and it will exacerbate so-called pain. What is pain again? It's just an electrical signal from a nerve ending to the brain that gets modified all along the way, modified by your brain, and you either perceive it as pain or not. So if you can decrease those inflammatory signals or those mechanical signals that initiate and then control the modification up and down, you're going to have less pain in your joints. You're going to feel better. You're going to have a better quality of life. So it's very important to get on a good sleep schedule if you want the capacity to self-repair. Okay, and then I told you we would talk about supplements. So these are supplements that I think are very important for joint health, and these pictures show you early arthritis or moderate arthritis really on the top, and then severe arthritis on the bottom. These are the substances that help, and I'm going to briefly tell you how. So omega-3, highly anti-inflammatory. So people that have a more omega-3 in their system versus omega-6, you may be saying, what is omega-3? It's a polyunsaturated fatty acid that is found in things like fatty fish, like salmon, mackerel, herring. And then in things like flax has ALA, which is then converted to omega-3s in your body. Omega-3s are highly anti-inflammatory. Omega-6s are highly pro-inflammatory inflammation. There's a ton of omega-6s in soybean oil, canola oil, corn oil, corn-fed beef, corn-fed chicken, corn-fed fish. A lot of fish nowadays have higher omega-6 levels than omega-3, particularly if they're farm fish. So if you have a lot of omega-3, it's highly anti-inflammatory, and it helps with the restoration of the normal extracellular matrix after any given type of damage, and that's been shown in some basic science studies. The flexibility of your body will be better on omega-3. It takes about 2 to 3 months to start to feel that little bit of looseness, but cell membranes, the surrounding, I guess think of it like a balloon, the outer shell of a cell, holding everything in together. The cell membranes, if they're filled with omega-6s, are stiffer. The receptors don't work as well, the channels and the pores don't work as well, and the cell's not as fluid and able to fit into spaces and mix and mingle with other cells as well. Omega-3 in the cell membrane makes it more flexible. So after enough time with enough omega-3, you can actually make your cell membranes a little bit more flexible and able to function well. And where is this hugely important? In your brain. This is why your parents always told you that fish was brain food, because omega-3s are brain food. So as much omega-3 as you can get, the better your brain's going to function, as well as all of your connective tissues. And then you're going to have better circulation health, and then more oxygen and nutrients to the tissues to help the self-repair capacity. Vitamin C is hugely important. Okay, we always think of vitamin C when you get a head cold or whatever, you're going to take it. It is highly anti-inflammatory, and it's one of the best single molecule antioxidants that we have. But it is also a vital cofactor for the enzymatic process that cross-links those braided collagen fibers together. So they're not just braided and not held, they actually have links between them to keep them working together and make them working properly. And the only way those proper cross-links are made is with enough vitamin C. So like anybody that's healing a wound or healing from surgery, in my hands, I highly recommend they get on vitamin C, because it helps all of those proteins in that repair mode that you go into when you're trying to heal a wound or from surgery. Vitamin C helps that happen. So omega-3 vitamin C, hugely important for better healthy joints. Turmeric. So the Joint Health Multi from the Well Theory, which is my line of natural products and supplements, has turmeric in it. It also has ginger and piperine. Piperine increases the bioavailability of the turmeric. Both turmeric and ginger have been studied for arthritis and have been shown in clinical, preclinical, and basic science studies to be effective in modifying or modulating the biomarkers and the different cellular components that are associated with osteoarthritis. Turmeric has been shown in many studies to reduce inflammation around the joint tissues and in the joint tissues, and it's been found to be as potent as many synthetic anti-inflammatory molecules. It downregulates the activity of that NF-κB gene I told you about earlier, which is highly inflammatory. So turmeric will downregulate the genetic activity of the pro-inflammatory gene, and it gets rid of a lot of the biomarkers that are associated with joint pain and inflammation. So turmeric is a great substance to take for arthritis. So most of my patients that come in that have arthritis that want natural protocol, I tell them the Joint Health Multi in the morning, tart cherry extract at night, and omega-3, if at all possible, if you can add that into the mix too, would be highly beneficial. Turmeric also inhibits the COX-2 enzyme, which turns those omega-6s in the cell membrane into the pro-inflammatory molecules. And then it inhibits those proteases we talked about, the metalloproteases. Turmeric has been shown in some basic science and preclinical work to inhibit those metalloproteinases. You don't get as much of that cartilage deterioration. Vitamin D, massively important, really for everything. So you'd be shocked how many people are D deficient. I routinely check vitamin D levels, if at all possible. Sometimes the insurance companies don't want me to. But you would be shocked how many people are D deficient. And then you start to get them on a good protocol of vitamin D, and most things get better. Their immune system gets better, their skin health gets better, eyes get better, their body function gets better, they're better able to move and be active, things like that. It is vital for bone health, you know that. Helps to regulate the calcium and phosphate metabolism going on. It's also vital for the immune system. I don't know if you remember this, but they've done a lot of studies, and MS is linked with low vitamin D levels. Susceptibility to the effects of COVID and flu and other viruses is linked to low vitamin D levels. Why? Because there's vitamin D receptors on immune cells. Where do immune cells hang out? In connective tissue. So vitamin D is hugely important to assist the immune system in the repair and restoration capacity. So the immune system isn't just there to fight viruses and bacteria for you. It is also there to clean up anything damaged or messed up in the system, get rid of it, recycle what needs to be recycled, and help bring in the remodeling proteins and the signals to the extracellular matrix. So vitamin D, hugely important if you want to have healthy joints and a healthy musculoskeletal system. Okay. Magnesium and zinc, also hugely important. Zinc is a cofactor for hundreds of enzymatic reactions. Again, after surgery or if somebody has a wound, I try to get them on zinc because it is just so helpful to that repair and restoration capacity of the human body. It's vital for the immune system function and optimization. So again, those damage control, so with a damage signal sent out by damaged cells, help repair that damage. Magnesium is also very important for muscle and bone physiology. 56% of Americans are magnesium deficient, which is terrible. Magnesium is found in a lot of fruits and vegetables and different foods, but again, none of us are getting enough of it. Most ultra-processed foods, they remove it. Sometimes they'll try to add it back and call it fortified, but really the best way is to get it naturally through a whole food diet. But I take magnesium because I'm pretty sure I'm not getting enough with my diet. Very important for muscle and bone physiology, very important for the mineralization of the subchondral bone. That is the plate of bone on which cartilage sits. And it's also needed for a cofactor for a lot of the repair capacity chemical processes that happen. And I find that if you don't have enough magnesium, your nerves tend to be dysfunctional and you have more nerve-based pain. So like people with restless leg syndrome, one of the first things I ask them is if they take magnesium. It's been shown in a lot of studies, and anecdotally, I think it works really well to help with things like that, and also with things like migraines. So magnesium, zinc, very important for the musculoskeletal system.
You have a question about how much to take of these supplements?
How much to take? So in the well theory, my line, each one is at a level that should help optimize your function, but still be well under any adverse events that might occur. And then, with things like magnesium and zinc, there's the salt form and there's the elemental. Well, your body can't handle elemental or absorb it, so everything's in a salt form. And then what salt it is, like zinc sulfate or magnesium glycinate or magnesium citrate or mag-ox, all of those change how many milligrams you take. So that's a tough question to answer. Omega-3s, I would say I take about 2 to 3 grams a day personally. Anywhere from 1 to 4 grams a day is probably good for omega-3s. Turmeric, I usually recommend about 1,000 milligrams of the pure curcuminoids, which is the active part of the turmeric root. D3, it depends on your levels. So some people are so low, I put them on 50,000 international units a week and tell them to take a daily supplement. Some people only need 1,000 units a day. Some people are genetically predisposed to not process vitamin D properly, so they need like 5 to 10,000 units a day. Everybody's different, but in general, if you look on the supplement packets, that's the average dose that's needed. So I think magnesium is at somewhere around 300 milligrams, the zinc somewhere around 50, calcium's 1,200, D3 in our thing is about 3 to 4,000 international units. But everybody's different, so you personally may need more or less. I just don't know. Tart cherry extract, I recommend 1,500 to 3,000 milligrams a day. And this is a highly, highly, highly potent antioxidant. So it will help you fight that oxidative stress that I told you is the fundamental problem with a lot of your issues. It helps to reduce muscle soreness and pain after activity, and that's been shown in some studies with runners. So a lot of my patients, when they go on tart cherry, they notice that a lot of their pain just gets better, particularly if they're adding it with the joint health multi and the omega-3s. It's a known way to help remedy the symptoms of gout because it'll pull uric acid out of the system and urate, so you won't have those deposits of those painful crystals in your joints, and it reduces inflammation in joint tissues. Tart cherry extract is extremely beneficial to your health overall, I think. Some people ask me, why can't I just eat cherries or why can't I just drink the juice? You could do that. I think if you want to eat 150 to 200 to 300 tart cherries a day, that's reasonable. You're going to get a significant amount of fructose with it, but at least that comes with fiber. But I would not recommend the juice because that's effectively just straight up fructose, which is highly pro-inflammatory. So I'd take the extract, which has been extracted from the tart cherries themselves. I don't drink the juice because the juice is just pure fructose, which is really just terrible for you.
We have a question. Like, is it safe to take it for an extended period of time?
They read it might be what?
Might not be good to use it for a long period of time.
Okay. Somebody asked, can they take tart cherry extract for years, or is that bad? So apparently they've been taking it for a number of years, but they read somewhere that if you're on it long term, it might be bad. I mean, if you ate cherries every day for your entire life, I don't think anybody would say that was bad for you. So I think with any of these natural things, if you're taking an appropriate amount, it's just like if you were eating it, right? It's just in a slightly more concentrated form. So I don't particularly ascribe to that point of view. What I will say is some people's systems respond better to cycling. So like you might want to take tart cherry extract 4 months, take a month off, 4 months, take a month off, something like that, where you cycle and oscillate. Just because some people respond better to that, you need that period of disuse, I guess, to reset the receptors in the system. But tart cherry extract in and of itself, I've read no reports of adverse events from being on it long term. I take it every day as well and have been doing that for years. I don't notice anything, and all my biomarkers are always good, and I never have pain, and I sleep well. So I think in theory, perhaps, but in reality, probably not. Ginger, we kind of already talked about. It's been studied head-to-head against things like ibuprofen and Aleve, and it works just as well for joint pain. Ginger is a good thing too because it actually helps with digestion. So if you take ginger extract, or you notice they give you pickled ginger when you eat sushi, it just helps cleanse the palate and help your digestive system. So a lot of these anti-nausea natural remedies are going to have ginger in them. So I'm a big fan of ginger, and I've combined it with the turmeric and the joint health multi for you guys. Next.
Do you have any thoughts on ice baths?
Do I have thoughts on ice baths? Yeah, I'm a huge fan of ice. I try to remind people about ice. Most people forget ice. Ice is one of the most natural, fundamental ways to treat joint pain there is. Yeah, like a cold plunge thing. I cold plunge every day, but I do it more for the longevity and brain health benefits and the stress management and ability to withstand stress, or the resilience aspects of it and the mental health benefits. Again, because I do all this other stuff, I don't have a ton of pain per se, but ice baths, obviously, every professional sports team in the world, their locker room is filled with ice baths for a reason. It reduces inflammation, it increases levels of dopamine and catecholamines in the brain, and it gives you sort of a sense of well-being while it diminishes the inflammatory response to any acute thing that may have happened on the field. And it lowers inflammation overall. So ice baths are a great thing. If you can stomach an ice bath, I'm a big fan. Okay, so these are more longevity molecules, but they too will help your joints function better. Resveratrol and NMN, nicotinamide monodinucleotide, I think is the molecular name. NMN effectively becomes, in a one-step chemical reaction in your body, NAD. NAD is one of the electron shuttles or carriers between the food you eat and the mitochondria. Levels of NAD drop as you get older, so supplementing with NMN helps your mitochondria maintain its health and maintain the ability to fight off the reactive oxygen species or oxidative stress and reduce inflammation. It promotes the more effective use of glucose, so that helps with insulin resistance. So NMN is a great thing to take as we get older to fight off the effects of cellular aging and mitochondrial dysfunction. Resveratrol, same thing. It upregulates the sirtuins, which are DNA repair enzymes, and NMN helps with that as well. And then that, of course, helps with your repair and restoration capacity. And they've actually studied resveratrol with Mobic, I think, in a study for osteoarthritis pain. And the people that took resveratrol with the Mobic did better than the group with just Mobic. Mobic being a prescription anti-inflammatory. So resveratrol is one of the longevity molecules. It's been associated with longer lived lives in preclinical or animal studies, as has NMN. So there's a lot of work being done on these molecules in the anti-aging world, but for our purposes, they'll just make your body feel really good now, and you have the potential benefit of longevity. Glucosamine and chondroitin, probably one of the most common ones out there, very well known. I don't have one of these in my line because there have been some reports that it's associated with insulin resistance. And until I delve deeper into that and do heavy research, I don't want to offer a supplement for joint health that might promote insulin resistance, which is damaging to joints. But effectively, glucosamine and chondroitin are thought to be molecules that will help with the formation and repair of cartilage. And they've been around for forever. Collagen, I get asked all the time, should I take collagen to help my skin? Should I take collagen to help my bones? Collagen, type 2 collagen, is the most common structural component of your extracellular matrix in cartilage. We talked about that. Type 1 collagen is in your bone. And then there's up to, I don't know, 11, 12, who knows how many types of collagens there are. They're all important. They're all basically just strings of amino acids. So as long as you're getting the amino acids and you have the cofactors like vitamin C that are needed to put it all together, and the micronutrients that are needed to put it together, I think you're doing okay. And remember, any collagen you take is typically broken down in the digestive system into the constituent amino acids or peptides. What's a peptide? It's just a short group of amino acids versus a protein, which is a long group of amino acids. So for me, the way I get my collagen is homemade stock for like chicken soup and stuff. So a whole food based method of getting collagen. And then there's these other substances, MSM, which is, let me see if I say this right, methyl sulfonylmethane. This is a sulfur containing molecule. Sulfur is a component of many good antioxidants, okay? Glutathione being one. It supports the health of connective tissue, it's thought. And again, what is it doing? Helping to promote extracellular matrix repair, as all of this does. And again, it might increase your blood sugar levels. So I'm a little bit I'm on the fence about that one still. Hyaluronic acid is a definite component of the synovial fluid and the extracellular matrix. It's a component of the amniotic sac. It's really found everywhere that you need good functioning connective tissues. Helps to retain moisture, helps to increase that lubrication so you have smooth moving, low friction joints. And it supports and cushions cells, particularly as a component of the pericellular matrix around the chondrocyte and then the territorial matrix. And it supports collagen health. Hyaluronic acid is what you're getting when you're getting Rooster comb injections or Synvisc. That is being put directly into your knee. We do a lot of those in my clinic. They seem very, very helpful, particularly for the early grades of arthritis. But if I can get someone to do all this other stuff I'm talking about, those are the people that go from on bone to doing great and having high functioning, pain-free lives. And we do have a hyaluronic acid coming out. It's just not, it's going through all of our testing and certificate of analysis and those phases right now, but it will be released, we think, in 24. All right, so we talked about the book that I wrote, and it's really been a labor of love. It's really hard for me to give these messages in a cohesive way to every patient I see in clinic. So I needed a bigger impact way to do it. And now I have this. That's why I'd spend Saturday every month doing the webinar, plus the time taken to prepare it, is really, I really just want people to get better without surgery and without drugs, if at all possible. And then the beauty of, if you do all this stuff I'm telling you about, if you have to have surgery, your outcomes are going to be massively better than if you didn't do all this before. So it's going to benefit you either way. So even if, let's say you followed everything I said to do in Bone on Bone to the T and you still needed a total knee replacement, okay, well, your outcomes are going to be amazing after that total knee versus the 20% of people who do terribly and hate it. So hopefully this gave you a snippet or a into cartilage and all of the complexity and the beauty of the form and function, not just of the physical, what you see as a joint, but down to the microscopic form and function and how important it is, and how you ultimately are going to be able to help control the repair capacity of your own body with just these simple little tools and tricks. Any other questions? Feel free to share and like this. I would love it if you did. And the book's available for pre-order. I'm supposed to tell you that as well. So it is published. It's on Amazon. And then also, these are all the things we talked about today. So the tart cherry extract. We even have an arthritis gummy that has boswellia, which is frankincense, bromelain, which is a component that's found in pineapple, also highly anti-inflammatory, and then PEA. I don't really talk about PEA because that's palmitoyl ethanolamide. That actually reduces inflammation at the peripheral nerve endings. So it helps with pain as well, particularly nerve-based pain. But PEA is a great natural way to modify your body's perception of pain. Pterostilbene is from the blueberry plant, and it's a different way to get the similar molecular responses, resveratrol, okay? It's considered to be a bit more bioavailable. And then the joint health multi we talked about a lot. The PEA we just talked about. CBD we didn't go into too much because this talk wasn't about that, but that is a natural molecule found in certain plants that is thought to impart changes in your natural endocannabinoid system and promote anti-inflammatory effects as well. So a lot of people will use topical CBD and or oral to reduce inflammation. And then the longevity, the NMN and the resveratrol we talked about. What you're not seeing here is the omega-3, the vitamin C, the zinc, the magnesium. The very first supplement that I made was the connective tissue multi, or the CBD multi, which had everything in it that I thought people needed to heal from surgery. Zinc, calcium, vitamin D3, magnesium. I'm sure I left something out. And vitamin C, did I mention that? Hugely important to collagen health. So hopefully this is helpful.
So we have a few comments like, I love your products, you're helping so many people, thank you.
Oh, somebody just said that they love my products and that I'm helping many people and to thank me. Thank you. I just love doing this.
Melanie said, this is amazing, very informative.
Thank you, Melanie. I'm glad you found it informative. Feel free to, if you guys have topics you want me to talk about, feel free to let my team know, and I'll put together a talk.
Oh, yeah. One lady did say, like, a webinar on autoimmune issues.
Somebody asked if I would do a future webinar on autoimmune. Yes, I will, of course, because it's fascinating to me, and it's really just a connective tissue extracellular matrix dysfunction problem related to the immune system. We've actually talked about autoimmune before, so if you go back through the catalog of talks, you'll find one. But yeah, I'm definitely going to do ones in the future because the body of knowledge is doubling now, like every nanosecond or something. So things change all the time, and I have to stay updated, and I'm going to keep you updated. The catalog for the supplements? Oh, the catalog for prior talks is on thewelltheory.com under Learn, Learn. She said Learn. I thought she said Lauren. Lauren is my nurse here in this picture. But it's under the Learn tab, not the Lauren tab. My nurse practitioner, yes. All right, we have more questions.
I mean, this was older. Can cartilage be replaced if it doesn't self-repair? You've already touched on that. Can you still be running after meniscus tears? They used to run marathons.
Okay, that's a great question. Somebody asked, can you still run after a meniscus tear? They used to run marathons. Did this person have surgery or not would be my first question. Most meniscal tears will self-heal and become asymptomatic. If you look at the literature, and this is in the book too, if you look at the literature on MRI studies of people with no knee pain whatsoever, the rates of meniscal tears are very high, up to like 60-70% of people over the age of 60 and like 40% of people in my age group. So a lot of people are running around with meniscal tears that have no symptoms. So if you just have a meniscal tear, yes, you should be able to still run. Now, if you've had surgery and had some of that resected, all of the studies now looking at the sham surgery studies, the long-term natural history studies, the studies after surgery show that meniscectomies enhance and propagate the formation of osteoarthritis. So the groups that have a meniscal tear that don't have surgery seem to do better long-term than the groups that do have surgery. But this is still one of the most common surgeries done in the country. So what can I say? Yeah, so this person had surgery. So if you want to still run, I would say make sure you don't have insulin resistance, make sure you have a good sleep schedule, get the right diet, and most importantly, make sure your alignment is okay, that you're not bow-legged or knock-kneed. So those are the people with the abnormal biomechanical function that seem to do worse long-term. So you can either get a realignment brace or just make sure you're more or less neutral. I would see a good physical therapist and make sure that your hamstrings are optimized to your quads and your calf muscles and your tibialis anterior, your heel cord is stretched out properly, that your hip is strong enough to handle running. All of this plays into your ability to withstand the stresses of running. That said, you don't have to run for the benefits of exercise like we talked about. Just walking is fine. But I know a lot of people that love to run. It really helps their mental stress. I get it. Just make sure you're as optimized as possible, even with a meniscectomy that's happened in the past. And just know that that knee is probably going to go south before the other knee because of the meniscectomy, not necessarily because of the meniscal tear.
I guess just to piggyback, someone says, can degenerative meniscus no surgery heal with your advice?
The question is, can a degenerative/torn meniscus heal with my advice versus having a surgery? Yes. Remember, the surgeries, typically you just remove one part. Nothing is healing after surgery. Sometimes we're able to actually repair a meniscus with like a little suture tack, and I've done these surgeries. In those cases, you're just stabilizing, letting all of the self-repair and healing capacity happen a little bit quicker. But yes, they can heal. Like I said, there's plenty of people with meniscal tears that end up doing great doing nothing. The body was built to repair itself. I mean, think about it. Nothing else makes sense, right? So yes, you have innate repair and restoration capacity in yourself. And I'm just telling you how to make that work the best way that I know based on all of the current knowledge. And again, this may change in 2-3 years, who knows? But I'm going to stay updated and keep you updated too.
Somebody said their daughter fell and broke their back. Surgery seemed successful, but so much here to help her heal.
Right, that's exactly what I'm talking about. Somebody just said their daughter fell and broke her back and had surgery. The surgery was successful, but they're going to take what we've learned today and apply it to her to help her recovery. Yeah, I mean, look, if you break a bone, generally surgery is needed. There are times when surgery is definitely needed, trauma like that being one of them. But yes, all of this is going to help the recovery.
Is there any way to naturally get rid of a bone spur?
Question is there a way to naturally get rid of a bone spur? Bone spurs are when you have a tensile force at the attachment of a tendon to a bone, or it's around an unstable, deteriorating joint under the stress of oxidative stress and chronic inflammation. What happens is the extracellular matrix gets very confused, and instead of making bone or cartilage, it'll make a spur into the cartilage. Like it just gets disrupted, or it'll grow bone into a tendon, like in the Achilles tendon. I think if you get the omega-3 levels right, reduce the inflammation, chronic stress, do the stretching that is appropriate and the movement that is appropriate, you can usually mitigate the symptoms of a bone spur. Sometimes the bone spurs will regress in size slightly, but they rarely just go away once they're formed. But you can definitely make them asymptomatic, make them where they don't bother you anymore. For instance, the healing sole is great for bone spurs associated with plantar fasciitis or bone cases associated with Achilles tendonitis. Are there any more questions, or does everybody need to go get ready for Christmas? One more.
When we say 2 pills a day are recommended dose, should I take them together or 12 hours apart?
Somebody asked if a recommended serving size is 2 pills a day, should they take them together or 12 hours apart? Again, that is highly dependent on the substance. So for instance, I take 2 NMNs in the morning and I take them together in the morning with something fatty to help them get through the digestive system better, because I want them in the system for the day. I don't necessarily need, to increase my cellular energetics at night. ALA should be taken alone on an empty stomach in the morning because that's how it absorbs the best. Tart cherry should be taken at night. And it can be taken 1 or 2 capsules together or separate. It doesn't matter. But I don't tend to take tart cherry in the morning because it naturally has a bit of melatonin. And I'm a big fan of my routine and my circadian rhythm, as we talked about. So I don't want melatonin in the morning. I only want melatonin in me at night. So it really depends on what you're talking about and what's the purpose of what you're taking. All right, well, hopefully that's good for you guys and you learned a little bit. I think the extracellular matrix is fascinating to me, and I think the key to everything. And as you see, the drug companies are starting to catch on to this, but I think you have some tools at your hand that you don't have to rely on that.
Can you create a presentation on plantar fibromatosis?
Somebody wants a presentation just on plantar fibromatosis. I could probably do that. That is a benign sort of, I hate the word tumor. It's a benign growth of connective tissue in the plantar fascia. We also see it sometimes in the hand and Peyronie's disease, which is on the penis. So sometimes connective tissues will form balls and become stiff and dysfunctional. And in the bottom of the foot, it becomes this bump that some people step on. Yeah, we could talk about that. That's just an extracellular matrix dysfunction, right? What? Yeah, I think we mentioned it in my plantar fasciitis talk that I did before. What I would tell you is try to avoid surgery for that if at all possible. There's really no great surgery for that particular problem, unfortunately. All right, everybody have a Merry Christmas, Happy New Year. Enjoy your holidays, and stay safe. Go to bed early. And thank you for watching. Oh, and thank you for the support. Yeah, of course. Thank you for tuning in and letting me teach, because I love it. And thank you for being interested in how your body works. It is amazing. And what? Oh, sorry. I'm getting a lot of cues. Can you tell? Thank you for being supportive of the well theory. I do really appreciate it. And I hope you all check out the book. I'm very excited about it. And I think you could just think of it as a guidebook, if you will. But it does go into a lot of why I think what I think and why I do what I do. Barbara?
Tell Barbara we're sorry.
Barbara, we're sorry.
All right, what about glaucoma? Do you have supplements for that? For the eye?
Oh, do I have eye supplements for like glaucoma? Glaucoma is a pressure problem in the eye. Most of my supplements are going to make the lens function better because that's a connective tissue. Glaucoma is a little bit different. I do not have a supplement targeting just glaucoma at this point. But that is something that you need to keep monitored very closely with your ophthalmologist. So I'm glad you're aware that you have it. And you're probably, if you're watching this webinar, you're probably in tune with your health, or at least want to get better. So I'm sure you're seeing an ophthalmologist. That is not something you want to let get worse. Oh, somebody loves the tart cherry and joint health. I do too. So thank you. Merry Christmas, everybody. Enjoy your day.